IVF since 1978, when an old hospital in Manchester, first baby was born, and Bob Edwards and Stepito both were involved in that birth of Louis Brown. From 78 till 2023, there has been tremendous changes in this field. It has fully established itself as a subspecialty, and it's become a need of the gynecologists particularly to acquire an expertise in this area. It is a challenging area. It's not so easy to really become technology. The best would be the one who can treat the patient, get a positive baby carry home result. That is the ultimate one has to achieve. Currently, if I look back from 78 to this date, there have been more than now 10 million babies who have been born through this technology. So you can see the impact it has brought and the happiness to the couples who have been benefited from this technology. Being deprived of a baby is like, it's more agonizing and equally agonizing as a cancer patient. This is research by Harvard University. There has been rapid changes, particularly from 2010 onwards, and there has been increasing use of artificial intelligence in IVF technology. Selection of embryo today is done through time-lapse. Semen analysis is done through CASA. As we have witnessed, that patients who grow old, particularly the female, their egg quality compromises and the chances of their pregnancy decreases perceptibly after 35 years of age. And after 40, we have seen that the positive results are very few. It's about 10 to 15% maybe. 50% of these embryos become abnormal and 50% are normal. But when we are doing these procedures in our lab, we are not aware which is normal, which is not abnormal, which is normal, which is abnormal. The technology through PGS, which has now been advanced and which is called now PGTA, that is applied, which can give you a selection, of having a normal embryo, and it can also tell you that this is an abnormal embryo. It increases the cost of the patient. Pakistan is a society where it is not funded by the government, and patients have to bring their own, they have to raise their own resources, their own money, and they are looking for one chance, and that one chance they want it to be 100%. It's so challenging and so difficult to meet that expectation of a patient to give them a 100% result in every chance, in every attempt. So we in Pakistan particularly work under pretty stressful situation. I feel I must congratulate those consultants, those doctors, those professionals, clinicians who are attached with this practice and they have adopted this practice as a regular practice, like Dr. Shasia. They have to face the brunt of these patients with their questions, and at times they're annoyed and they're angry and they want to blame the clinician, the center for their failure. It is not so. What has been going on so far, what I've seen going around the world, attending so many conferences, the results, the nature has made human beings the least reproductive species. It's just 33% chances of a pregnancy the human beings enjoy. They don't have that reproduction ability as other species have. Like lion will have 100%. Similarly, when we are talking of ART, the assisted reproductive technology, the chances of pregnancy do not really improve to 60% or 70%, 80%. In a couple who are married to each other, and it's a non-donor cycle. It remains around in the age group from 20 to 30 years of age group. You can say that you can expect about 50% result in a good center with all management skills and quality assurance. There's a lot of artificial intelligence which is used in the lab to ensure quality nowadays, and a good lab must have a 90% plus fertilization rate, and they must be able to at least, from observational point of view, select the best embryo for transfer. These are a couple of things which make chances of a better result. Then there are protocols which people have to learn. Ovarian stimulation is an art. The clinician has to select, they have to see the patient. They have to keep everything in mind, the age group of the patient, the BMI, the patient, any previous histories. They must eliminate all factors which may bring an adverse impact on the pregnancy. They must ensure that these patients, they must give some time before they put the patient on an IVF cycle, that is the IVF workup. Before the patient is brought onto the cycle, they must work up with that patient and ensure that everything is in line and she has got optimum chance of getting pregnant. And that is how it will improve and eliminate a chance of any error if the clinician may occur during the treatment. If they are planned, they know their dosage, they can calculate and they can be prepared of what type of a patient they are dealing with, and just it doesn't need a lot of time, but a habit of going through, cultivating that scanner in your mind and in your eyes to eliminate any chances which can adversely affect the impact of outcome of that patient should be eliminated, should be treated, and patient should be in optimum health ready for a pregnancy. And then having the right dose, ovarian stimulation, controlled ovarian stimulation to get the best number of embryos, eggs, and good quality of eggs. And maybe they are few, but it doesn't matter they are few, but they have to be good, and it should be rightly at the right time. The patient should be triggered, and the lead follicle, which is the lead follicle, basically when the menstrual cycle begins, FSH is secreted, and the eggs are lying in the both ovaries, and every egg which is ready for that cycle starts absorbing FSH, which is being secreted from the pituitary signals, and that FSH, one of the follicle has the ability to take more FSH, and that FSH, the ability of that for that egg basically shows that it's more healthy, it is a better one, and it is absorbing FSH better than the others. And as by day 6 or day 7, the lead follicle, the dominant follicle, the one which will become the best one, is almost visible. You can understand that this follicle is going to be the lead one. The rest will gradually go into atresia as is impact of other hormones come, this follicle, there's the natural cycle I'm describing. The same pattern follows in, IVF, when we're giving stimulation to such patients. Similarly, we have a cohort of follicles which are developing and they're falling, but at times we see an erratic behavior. One follicle goes ahead and rest of the follicles are coming back, which a long time, there's a gap between them. And sometimes what the clinician is targeting is they lose the lead follicle and they wait for the rest of the follicles to come forward, and the best follicle is gone, and the rest of the follicles, of course, they mature. They have to make their decision when to really trigger their patient, and the day they trigger their patient, it still continues to grow. So even a follicle which is 17 mm on that day, and there are follicles which are 15 mm or 16 mm behind them, and a couple of them are there, they all will become finally mature at the time of pickup. So I'm happy that Dr. Shah here today had a very detailed, presentation on frozen embryo transfer. It has got disadvantages, no doubt, and effectively used, it brings better results. Fresh embryo transfers are not bad, and they also bring results. It's not that it's the only frozen embryo transfer. There are cases to cases, and from each case you have to take your decision as their, your experience will teach you what to decide for which patient to be done in the fresh cycle and which patient to be taken to the frozen cycle. So it's a learning process which is going on, and as we move on with the more development in science and innovations and artificial intelligence coming in and stem cells coming in and things like that, they say that in future, in 1940, there will be no IVF. The entire technology will be replaced. So that is how we are moving forward. And thank you very much, everyone, and I am pleased to see you. It was a wonderful day. All the best.